Hello everyone and welcome to the third in our TRSP Webinar Series. I'll introduce myself first. I'm Julia Lappin. I'm the Clinical Director for the Tertiary Referral Service for Psychosis, henceforth TRSP. I'm a clinician and researcher working as Associate Professor at the NSW School of Psychiatry, and I have over 20 years experience working clinically and in research aimed at improving outcomes for people living with psychosis. Today, I'd like to begin with an acknowledgement of country and of lived experience. I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we are joining this meeting. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation. I pay my respect to the elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families or supporters. So, welcome to the Mindgardens TRSP Seminar Series for people with complex psychosis. The TRSP is a New South Wales health-funded statewide service hosted by South East Sydney Local Health District. We're very grateful to South East Sydney LHD and to New South Wales Health and to the Mindgardens Neuroscience Network for their ongoing support of TRSP. The TRSP aims to improve lives of people living with complex psychosis, and we do so through the delivery of our clinical service, which welcomes referrals from across the state of anyone who's living with psychosis and who is cared for in New South Wales public mental health services. We also run education and training programs aimed at developing a community of practice for capacity building in complex psychosis care, and this webinar series is an example of one such program. This webinar series is supported by Mindgardens Neuroscience Network. Mindgardens is a partnership between members Neura, the Black Dog Institute, UNSW Sydney and South East Sydney Local Health District. Mindgardens was established in 2019 to enhance collaboration between those members and to build translational research capacity in mental health, drug and alcohol, and neurological disorders. Our Mindgardens TRSP Seminar Series will run throughout 2023 monthly. We now have a full programme ending in November 2023, and we can provide details of that to you. So please look out for emails from the TRSP events, which will detail future webinars, all tailored for clinicians working with people with psychosis. So before I hand over to our speaker, we've just got a little bit of housekeeping. Please, anyone who's part of the webinar, you can write questions or comments in the Q&A, but you won't be able to speak or be seen. There will be a simple anonymous poll towards the end of the webinar. Please complete it as it helps us understand how worthwhile this webinar was. We also genuinely appreciate your feedback. You can email us, and in that, if you would like to include topics you would welcome at future webinars, we'll try and address those in future meetings. This event is recorded, and we will distribute a link to the event video within 2 weeks to those of you who've provided an email address. You can opt out of our communications at any time with a return email with unsubscribe in the subject line. Finally, it's my great pleasure to introduce Dr. Pramudie Gunaratne, who is a psychiatrist and public health doctor. She's a senior research fellow at the Department of Developmental Disability Neuropsychiatry, otherwise known as 3DN, at the University of New South Wales. She's the co-founder of the Seriph Clinics, a specialist private service caring for people with complex neuropsychiatric disorders. She also serves on the board of directors for the Royal Australian and New Zealand College of Psychiatrists. Dr. Gunaratne completed her clinical training in psychiatry across multiple sites in Sydney and was awarded a fellowship in Intellectual Disability Neuropsychiatry by the New South Wales Health Education and Training Institute. She's also worked as a consultant to the Brain Health Unit at the World Health Organization in Geneva. I'll now hand over to you, Pramudie. Thanks very much.
Hello. I'm just going to see if I can screen share. So bear with me. Is that coming up with the full screen mode? Great. Awesome. So hi, everyone, and thank you for taking the time out of your busy day to listen to this talk on intellectual disability neuropsychiatry. I also wanted to start by acknowledging that I'm doing this talk from the unceded lands of the Camaragal people, and I wish to pay my respects to the elders past, present, and emerging. So in terms of a bit of an outline for the next hour or so, we'll start by covering some core knowledge initially. So looking at some definitions, some statistics, and also trying to understand how intellectual disability intersects with serious mental illness. We'll then move on to some more sort of clinical, sort of practical part of the talk, where we'll go through some tips for assessment, for management, as well as looking at some common presentations. And we only have an hour, and each of these topics could really be a talk on their own. So we're really just going to have an overview around these issues. And finally, a common problem that people have is where they can access specialist care from. So I'll provide a bit of an overview of the intellectual disability mental health service landscape in New South Wales as well. So starting off with some core knowledge. It's always helpful to start off with a definition. So what is intellectual disability? And for this, we'll go straight to the source and look at the DSM-5 definition of ID. So there are three main criteria in order to define an intellectual disability. First, the person needs to have a below average intelligence on clinical assessment and testing. Generally, this is an IQ score of about 70 or less, which is roughly 2 standard deviations from the average population intelligence. But of course, measured IQ is just an approximate sort of global indicator of intellectual functioning. And it doesn't necessarily always correlate with a person's level of functioning or the skills that they may have. And there can also be lots of variation between the different domains in IQ testing. So we might miss that a person has various strengths and weaknesses in different areas, which isn't captured in a single IQ score. So the second criteria for understanding a person with intellectual disability is their level of adaptive functioning. So there are broad categories in terms of different types of adaptive functioning, which we'll go into. But in general, these are sort of age-appropriate behaviours that people need in order to live independently and function safely in their everyday life. And finally, the last criteria is that the deficits have to occur during the developmental period. So it has to be a deficit that's recognised from birth or childhood, anywhere before the age of 18. So if the onset of deficits or below average IQ occurs after the age of 18, this is usually due to a sort of trauma that might have occurred to the brain, which we'd refer to as an acquired brain injury, or it might be due to a neurodegenerative disease such as a dementia. But these categories don't fall under the sort of umbrella term of intellectual disability. And in some ways, this age cutoff might seem like it's a little bit arbitrary, but it is important in terms of understanding what services a person might have access to. And then when it comes to understanding the severity of an intellectual disability, we usually use adaptive functioning to understand this. And the severity is broken down into mild, moderate, severe, and profound intellectual disability. And we look at different adaptive functioning. So the range would be looking at conceptual skills. So these are things like someone's ability to use language, to read, to write, to do maths, their ability to self-direct, and all of that falls under conceptual skills. Then we have social skills. And these are someone's interpersonal skills, their social judgment, might be sort of how gullible they are or easily led they might be, and whether they can understand and obey sort of basic rules. And then finally, there's the practical skills. These are things like personal care, job responsibilities, whether someone can manage money, the ability to navigate public transport, use technology like phones, and all of that falls under the practical skills. And again, we have IQ scores, which sort of provide a rough approximation for severity. On the mild spectrum of intellectual disability, people can be supported to live independently. They'll be able to read, write, engage in some sort of vocational activity. And then there's a gradation in these different skills as we move through the different levels of severity, right down to profound intellectual disability, which is usually an IQ score less than 25, where a person would require extensive supports. And it's important to note that a majority of people with ID would fall within this mild category. And the support needs of people within the sort of borderline or mild intellectual disability may not be very obvious if you're not attuned to it. So it's important to really consider whether a mild level of ID may be at play in the patients that we see, because it's only when we recognize that this might be the case that we as clinicians can provide supports to help a person engage with a health assessment or to follow a treatment plan. And it could be really simple things that we might do when we recognize this, whether it's giving more time, whether it's using simpler language, or breaking down treatment steps into a clearer sequence. And so really being attuned and understanding whether someone might have an intellectual disability when we see them in clinical practice. So what's the prevalence of ID? Worldwide, the estimate is between 1 and 2%. I think we might have the poll in the wrong section, but that's all right. We'll come back to this. I'm just not sure how to move the poll out of my screen. But we'll just keep going. So the worldwide prevalence of intellectual disability is between 1 and 2%. But in Australia, we estimate that about 1.8% of people in Australia have an intellectual disability. So that's more than 500,000 Australians living with an ID. Julie, I'm just wondering, I can't move my slides onwards because the poll has popped up.
Okay, I'm sorry, Pramudie, it shouldn't be interrupting your slides. I don't know why it is. Let me try and move that. How's that going now?
Oh, there we go.
There we go.
Slide.
Okay, and apologies for launching the poll at the wrong place.
That's okay. We'll come back to the poll. All right, so now we're sort of looking at what the different causes of ID might be. So there are a range of different causes. Firstly, it might be a genetic cause for intellectual disability. So chromosomal abnormalities, one that most of us would recognize would be Down syndrome or trisomy 21. It can also be other mutations or syndromes with a known genetic cause. One that might be important to this audience is DeGeorge's syndrome or villofacial syndrome. This is important because it increases the chances of schizophrenia. But outside of genetic causes, there might be something that occurs in utero that causes an intellectual disability, something to do with maternal health, nutritional blood supply to the fetus, or if there's an infection during pregnancy. And then the neonatal period is also particularly a period of vulnerability for intellectual disability. So prematurity used to be a really important risk factor for developing ID, but this is improving in recent days as we've had more advances in neonatal care. A trauma, particularly a head injury that occurs during this period, can cause an ID, as well as hypoxia. And then in the postnatal period and during childhood, people who have head injuries may then have an intellectual disability. If you have an infection, particularly an encephalitis, this can lead to an ID, seizure disorders, and there's really a whole range of potential disorders that might lead to someone having an intellectual disability. So a proper developmental history is really important in this population if you're wondering about an intellectual disability. So that's a little bit of a primer in terms of intellectual disability. But how does intellectual disability intersect with mental illness? So this was the poll, which is what is the prevalence of mental illness in people with intellectual disability? So I might just wait to see. Great, we're getting lots of answers. Great. I'll just keep, so I think the leading response is about 30 to 40%. I can't move it to the next slide, Julie. Do you need to stop the poll before I can do that?
Should be able to move it now, Pramudie.
Thank you. Oh, still not working.
Try now.
I might stop my screen share and see if I can just get rid of it. Oh, no, still not working. Has that worked now? Yes. Okay, great. Julie, maybe we won't do the polls for the next questions, and we'll just I'll just go through the questions.
Sure.
Okay, great. So prevalence of ID, I think the polls were, the leading answer was around 40%. So let's try and put this in context. So in terms of the general population, about 20%, so 1 in 5 of us will have a diagnosed mental illness. In terms of carers, about 30% of carers will have a mental illness. And people with ID, the conservative estimate is about 40%. So I think well done to everyone who got that. But it can be as high as 50%. So really, the levels of mental illness in this population are far exceed that of the general population. And it's really important to consider the possibility of a mental illness when people present to our services. So the second question is going to be, what psychiatric diagnoses are common in people with intellectual disability? I might let you think about this one rather than going to the poll. And really, this was a bit of a trick question because the types of mental illnesses that occur in people with ID really stretch across the full gamut of mental health diagnoses, from mood disorders to psychoses to anxiety disorders, ADHD, substance use. And I think this really underscores the importance of screening for all of these in people with ID, just like we would for all of our patients. It wasn't that long ago that we assumed that people with ID couldn't have mental illness, but now we know that this is absolutely not true. So not only are the rates of mental illness higher in people with ID overall, but the rates increase further relative to the degree of disability. So the more severe the intellectual disability is, the higher the rates of mental illness. When we consider things like schizophrenia, affective and anxiety disorders, people with ID are 2 to 3 times more likely to have these. And schizophrenia also generally has an earlier age of onset in people with intellectual disability, which might underscore specific developmental vulnerability to mental illness. It's also important to consider the possibility of comorbid neuropsychiatric diagnoses. So almost a quarter of people with ID will also have epilepsy, but also looking at diagnoses like dementia, autism, tic disorders, and movement disorders within this population. So why do you think there are such high rates of mental illness in people with intellectual disability? Again, I might leave you to think about that a little bit. But when we consider the full sort of biopsychosocial spectrum, we can see that people with ID have multiple compounding vulnerabilities for mental illness. which means that they are at risk for a range of reasons. And if we break this down further, we can see that from a biological perspective, there are multiple inherent vulnerabilities that people with ID face. There might be a genetic risk that increases the vulnerability to mental illness. Biologically, this population has a more vulnerable brain, and they're also more likely to have physical health issues or sensory impairment or pain. And there's also a greater biological vulnerability to the effects of drugs. So these are both prescribed and illicit drugs. And also lifestyle factors like diet, exercise, and sleep may also be a factor. And then if we consider what the psychological vulnerabilities might be, people with ID are more likely to have experienced past negative life events, things like bullying, neglect, abuse, grief. And if you couple this with the fact that they may have fewer coping strategies to deal with these and to regulate emotions, then that adds an extra level of vulnerability, as well as associated issues like self-confidence and self-esteem. And then from a social and environmental perspective, this population experiences really high levels of stigma. They may be more socially isolated. They might have less opportunities for meaningful activity. And then even if we consider all the different sorts of social determinants of health, things like wealth, living conditions, socioeconomic status, again, unfortunately, people with ID often don't fare well on most of these metrics either. Of course, these are generalizations across the population. So as you can imagine, these vulnerabilities can compound, they can intersect, leaving people with ID more vulnerable overall to mental illness. And when I look at this list, I always think that people with ID have a lot of rich material in terms of formulation and in terms of understanding their presenting issue. So when we're considering our management as well, it's really important to consider the full spectrum of the biopsychosocial model so that we can tailor our management plans according to the specific issues that might be at play for the individual. And when we consider the impact of these things, it becomes really clear that the health disadvantage and the barriers to care for this population is absolutely pervasive. So it occurs across the lifespan from the perinatal period right through to old age and across multiple areas of health as well. So whether it's mental health, physical health, preventative care, primary health care, end-of-life care, we see that there is a health disadvantage for people with ID. And there's a range of reasons for this, but one important one is that clinicians often feel ill-equipped or undertrained to care for this population. And the overall result of this is that the onset of frailty for people with ID is about 25 years younger than the general population. And people with ID die about 27 years younger than the general population in New South Wales. People with ID also have double the proportion of potentially avoidable death compared to the general population. So if we take this all together, we have a population which has more physical and mental illness. They have a greater morbidity and mortality from that illness, and they have less access to care. So together, this creates the perfect storm for greater disability and greater illness. So I suppose one of the things that I've observed in clinical practice is that when people with ID present to emergency departments or to our services, often in distress, they are often told that this presentation is just to do with their intellectual disability, or it's just behavioural, and they are discharged home, often to re-present again. So the point that I really wanted to emphasise is that people with ID do have a really high risk of pathology, and they require our time and our effort for a thorough screen and a thorough assessment, just like every other member of our population. And of course, we have an ethical imperative to provide best care to this vulnerable population, but the economic argument is just as strong. In New South Wales, we estimate that about 1% of our population has intellectual disability, But this population then makes up 6% of our mental health population. And then when it comes to the proportion of the mental health care budget, people with ID use up about 13% of the entire New South Wales mental health care budget. So the expenditure is really quite disproportionate to the population. And I think these issues are best summed up in the interim findings of the Royal Commission when they looked at the healthcare of people with intellectual disability, and they concluded that based on the evidence, we found that there has been and continues to be systemic neglect of people with cognitive disability in the Australian health system. And I feel like so far I've brought a lot of doom and gloom. But I think the flip side to this is that there is a lot of opportunity to do better, certainly at the health system level, but also as individual clinicians, how can we better serve this population? So I'm hoping that this is a nice segue to talking about some clinical concepts that might help us to better care for this population. So first, an important diagnostic consideration is what is the severity of the intellectual disability for the person we're seeing. At the mild end of the ID spectrum, psychiatric disorders are often really similar to the general population. So patients are likely to be verbal, and you might need to consider how you phrase questions in order to make them clearer, but the presentations will be fairly similar. So it's important at this spectrum, this end of the spectrum, to be aware of phenomena like acquiescence. So this is where a person might give an affirmative answer to every question and just say yes, or suggestibility, where they might give you the answer that you expect. And so generally, we try to use open-ended questions and avoid closed questions or giving alternatives. For example, was your sleep good or bad? Instead, trying to keep the questions much more open. But as we move towards the more severe end of the ID spectrum, we find that psychiatric disorders might become more atypical, and you might have to rely on other cues or behavioural equivalents to understand what's happening for the person. These are markers like their sleep, their appetite, any changes in behaviour. Patients might appear more regressed. And it's really important to take a good history from their carers to understand what the changes are from baseline. Two important concepts to understand when working with this population are diagnostic overshadowing and baseline exaggeration. And I like to think of these as sorts of two sides of a coin, but both are really common in clinical practice. So diagnostic overshadowing, this is when a clinician attributes changes in mental state to the intellectual disability, and they may not consider what's actually changed for the person. And is there a psychiatric or a physical health diagnosis that I'm missing here, rather than seeing the intellectual disability as being the cause of the presenting illness? Some common examples of this might be grandiosity for someone with intellectual disability might seem much more mundane than we're used to. For example, imitating a staff member or thinking that they're able to drive when they actually don't have a license could be a sign of mania. Things like pacing and agitation might be interpreted as anger, whereas in fact, the person might be experiencing a manic episode. And one thing we often see is that physical illness, things like pain and medication side effects, are frequently missed. An example of this that I recently saw is a patient that I currently care for in private practice. He's a young man in his early 20s with intellectual disability and autism, and he's nonverbal. He has other siblings also with intellectual disability, and his parents described him as the most easygoing of their children. And generally, he hasn't needed any mental health input for most of his life until he's now hit his 20s. And during this time, there was a fairly acute change in behaviour, where he started to become really agitated. He was yelling, head banging, punching holes in the walls at home, and he was really unmanageable by the family. And he presented to their local emergency department multiple times and saw a range of doctors in the private system. And his behaviours were treated with a range of psychotropic medications, from antipsychotics to clonidine to anti-anxiety medications to lithium. Really everything was thrown at this person. And it got to the point where their wonderful parents got their local member of parliament involved, and this young man was finally admitted to hospital. And the hospital essentially closed one of their locked dementia wards so that they could nurse this young man. And he was there for months with full-time carers until a supported accommodation could be organised. But things just weren't getting better for this person. And everyone was really treating the behaviours, but not considering what the underlying cause might be. I only saw this patient about a year into all of this. And when he was referred to a special care dentist, we found, and his teeth were able to be examined under a general anaesthetic, we found that this young person had 4 impacted wisdom teeth and a giant dental abscess, which was likely there for months, if not the year. And it's a really awful story about diagnostic overshadowing, but unfortunately it's all too common. And I think for most of us working in this field, we can provide multiple stories of similar situations where behaviours are treated rather than considering what the underlying issue might be. And then of course there's the flip side to diagnostic overshadowing, which is baseline exaggeration. This is where a person with ID may have some odd behaviours, and without proper investigation or understanding, we mislabel these as illness, and often we go on to medicate these symptoms. Some common examples might be things like fantasy or magical thinking being interpreted as psychosis. Also, people with ID might have some unusual sort of or unique coping or self-soothing mechanisms, and these again are interpreted as psychosis. Crying or having sleep problems might not be a sign of depression, but it could actually be a normal sort of grief or bereavement response. And doesn't necessarily have to be to do with death, but it might be that a co-resident in the group home has moved out or a beloved support worker has left. And in people that have issues with communication, when they lose interest in an activity that they previously really enjoyed, we might see this as being a sign of depression. But again, it might be that they've simply outgrown the activity and it's no longer as rewarding as it used to be. Like it would be for all of us in terms of activities that we've gained and lost interest in as sort of a normal process. One of the best ways that I find to guard against both diagnostic overshadowing and baseline exaggeration is to really understand what the baseline is for the patient that you're looking after. And when I'm understanding a patient's baseline, I usually divide this into 3 areas. So firstly, understanding the developmental profile for the patient. And this can give you an idea in terms of the patient's developmental age compared to their chronological age. This might include looking at their motor and sensory development, so asking questions around coordination, balance, can they catch a ball, how they're doing up their buttons or their zips, do they have any sensory sensitivities? Also looking at their self-care skills, so what do they like at dressing, eating, toileting, doing chores around the house, and assessing their receptive and expressive communication or language skills across different modalities. Also understanding what's their capacity for social interaction. How are they taking turns? What's their emotional recognition like? What's their theory of mind like? And then also assessing what is their appreciation of time. And I think these are really important in terms of understanding the patient's baseline, but also it gives us a guide as to how we might be able to interact with the patient and how we can pitch our assessment. The next component of understanding baseline is understanding what are the expressions of well-being like for the patient. So getting a feel for the person underneath the disability. And what is it that they like? What do they dislike? How do they express their preferences? What are their usual activities? An example of this is a patient that I have who is absolutely obsessed with birthdays, her own birthday and also the birthdays of everyone she knows. And she has cognitive deficits in other areas, but she always remembers everybody's birthday and she gets really excited. She helps bake cakes and she loves to celebrate. So for her, when she lost interest in this activity, when she stopped remembering birthdays, it was a really significant change for her. And it's only through understanding that history, when her mum told me about her cognitive changes and loss of interest, was it apparent how important this was in terms of understanding the changes in her. And again, I find that understanding these expressions of well-being are a really good way to understand baseline, but also they're a really good way to build rapport. And I often find that it's really enjoyable to get to know your patient as a person beyond their healthcare issues. Finally, understanding baseline in terms of physical health is really important. If your patient has a syndrome, then understanding what the behavioural phenotypes and the potential comorbidities associated with that syndrome can be really helpful. For example, a patient who has Fragile X syndrome, they might have autistic features as part of their behavioural phenotype. So things like gaze avoidance or social anxiety could be part of that syndrome. Whereas someone with Williams syndrome, their behavioural phenotype includes a personality that is highly affable. They might be hyperverbal, and they really engage readily with strangers. So in assessing that person, it's important to know that's part of their syndrome. And when we think about comorbidities, again, if you take the example of Fragile X, 50% of people with Fragile X will also have ADHD as a comorbid syndrome, and have increased chances of seizures as well. If we look at people with Down syndrome, they have an increased chance of early onset Alzheimer's disease, as well as thyroid dysfunction. So understanding all of these is really important. But of course, I don't expect that everyone will know about all of the different types of syndromes. So in the next slide, I've included a link to the SSBP website. And this is a really great resource which provides these syndrome sheets, which is a really great reference to look at if you have a patient with a specific syndrome and you want to know more about it. We've already touched a little bit on pain and neuropsychiatric diagnoses that are important to consider. But in terms of clinical practice, the main types of pain symptoms that I encounter would be dental pain, as I've already mentioned in the previous case. And the recommendation is that people see a special care dentist about 6 monthly. Other common types of pain to consider would be reflux and constipation, as well as headache. And we've gone through some of the neuropsychiatric diagnoses. And a great tool that might help understand a patient's sort of physical health is the Comprehensive Health Assessment Program. And if you Google this, you'll be able to access this tool. And I believe it's created by the University of Queensland. So this is the website with the syndrome sheets from SSBP, or the Society for the Study of Behavioural Phenotypes. And these are available for all levels of clinicians and carers. So let's touch briefly on behaviours of concern. This is a common reason for referral for a mental health clinician. And sometimes we might use the term challenging behaviour, but I think it's the preferred term is behaviours of concern. So usually for behaviours of concern, we get referrals when people are exhibiting self-injurious behaviours. These are things like biting, skin picking, head banging, as well as behaviours that are socially disruptive, assaultive or destructive. When patients are doing these things, they're often readily referred to psychiatrists or to mental health services. But it's also important to screen for the not so obvious behaviours of concern. So things like abnormal eating or pica, non-repetitive functional behaviours like tics or stereotypies, as well as behaviours that might be harmful to health like smoking or substance use. And it's probably becoming quite apparent that this phrase is a bit of a pet peeve of mine. And when I hear it, this is usually my face, and this is usually what I'd like to do, because nothing is just behavioural. And in general, behaviours may signal that there is an underlying psychiatric or mental health issue for the patient, or the behaviour might serve some sort of function, or it might be a way for the person to communicate, or it serves a function. And it's our job as clinicians to investigate, to understand, and to formulate these behaviours so that we can help our patients and their carers and families manage these behaviours. So new onset or an escalation of behaviours always requires a medical assessment or a psychiatric assessment. And it's important to avoid premature explanations or dismissing these behaviours. I always find it's really helpful to get carers and family to precisely describe the behaviour. For example, he hits with his clenched fist without aiming is much more helpful than aggressive behaviour. And also behaviours may not necessarily represent disorders, so there might not be a medication solution. And objectivity can be difficult when we're discussing behaviours of concern. And so I always find it's really helpful to get carers and families to systematically record these behaviours, their frequency, their duration, their intensity in behavioural charts, as well as to explore triggers and consequences for these behaviours using an ABC analysis. So an ABC analysis, this stands for antecedents, behaviour and consequence. And it can be really helpful when history taking. So the middle portion of this graph is looking at the actual behaviour, understanding what it is, getting a prescribed description of it, and then considering what are the triggers or the antecedents to this behaviour. And this can be divided into external triggers. So what was the location, the time of day, who was around when it happened, as well as internal things for the patient, like what were their emotions like, what memories may have they been experiencing during that time. And then looking at the consequences. So after this behaviour occurs, how do the people around them react to that behaviour? What eventually happens and how does it resolve? And what does that behaviour achieve? And this can help us understand what the function or the communication may be from these behaviours. And usually you'll have a behavioural support practitioner who you might be able to get on board in order to present and to analyse these behaviours in a behavioural chart. And they'll be able to provide a behavioural support plan to the patient and their family with some strategies for how to deal with these behaviours. Speaking to carers is a really important part of assessing people with intellectual disability. Sometimes the relationship between the carer and the patient might be like this, where you have a really switched on carer who seems to be really in sync with the patient. Other times might be a little bit more like this, but more often than not, it's somewhere in between, and there's a mixture of these two situations. So when working with carers, it's really important to understand what is their level of knowledge about the patient, and to not fall into traps like the daytime support worker may not really know much about sleep patterns for the patient, and we need to distinguish between observations versus interpretations. So what do they actually observe and see versus how does the carer interpret those behaviours, separating those two things out. And being careful not to assume that because a carer is articulate and fluent, that they're providing an accurate history and really interrogating and understanding what might be going on for the patient. Also, that abnormalities, which are socially intrusive or undesired, are more likely to be reported, but it's our job to then screen for some of these less obvious behaviours, the signals of things like depression or anxiety, which may be underreported. And also, again, getting that really precise description. And finally, when we encounter discordant information, it's very common that when you have multiple sources of information, that there might be disagreement. But to consider whether this is actually contradictory information, or does it represent that the underlying condition is fluctuating, and trying to tease those two things apart. Now, prescribing in people with ID. First of all, it's important to understand that non-pharmacological strategies are just as important in this population, and psychological strategies can be adapted for this population. But when we are prescribing, it's really important to define a target for that treatment. So not just treating behaviours, but what is the diagnosis or the issue that we're aiming to treat with this behaviour? And always involving the patient, getting consent before starting any medication. The old adage, start low and go slow, is really important for this population because of the underlying brain vulnerability. Patients in this population are very vulnerable to medication side effects during initiation as well as during withdrawal of the medication. So going really slowly as we do this, and we might find that the required medication dose is much less than we expected. And having a means for measuring effects and side effects of medication, whether it's through a behavioural chart, and usually trying to choose medications which have less requirement for things like blood tests for monitoring, which might be more difficult in this population. And finally, considering medical comorbidities, for example, avoiding medications that might lower the seizure threshold, or being cautious when these are prescribed, knowing that patients with ID often may have dysphagia or swallowing difficulties. And when we consider some of the medications we use, whether it's sedatives, anticonvulsants, or antipsychotics, they can affect neuromuscular swallowing controls. And so being wary of that. Also, when it comes to gastric motility, medications that slow this down for patients that have chronic constipation, it's really important to consider the impact of this. And of course, a lot of psychotropic medications have cardiometabolic risk factors. So understanding this and mitigating against this. And as always, trying to avoid polypharmacy in this population. So one of the key challenges for people with intellectual disability is how to access care. And one of the challenges for this population is that patients often straddle different sectors, whether it's mental, physical, or the disability sector. And so ideally, we would want patients to be able to move between these sectors and get sort of the required services at the required time. Unfortunately, often the system looks a lot more like this, and our patients can fall through the gaps. And so part of our responsibility is to try and advocate for our patients to access care and to build bridges between these different sectors, particularly given that the disability sector is funded and governed by the NDIS, which sometimes doesn't have a lot to do with the mental health sector or the physical healthcare sector, which is funded and governed by sort of public hospital systems or the Medicare system. This was just to illustrate that health systems are really complex. And so it's very understandable that our patients and also us as clinicians might find it difficult to sort of navigate these complex health systems. When it comes to looking at mental health care specifically, in New South Wales, we have a tiered system. So we have the statewide Intellectual Disability Mental Health Outreach Service. And this is, patients can be referred to this service. There are also 6 intellectual disability health services. So these aren't specifically to do with mental health, but I think at least 2 of them do have psychiatrists who specialise in ID working within these services. And then the majority of patients with ID, particularly in the mild to moderate spectrum, we expect would be treated within mainstream mental health services. There's also the private system where there might be private specialists or private psychiatrists who can be referred to, as well as NDIS services. where we might be able to refer patients to. Importantly, NDIS doesn't fund doctors, but they do fund allied health, which is a really important part of the care team. There are more than 6 different LHDs. So this slide just shows which service you might be able to refer to depending on the LHD that you work in. And finally, I just wanted to point towards some resources that might be helpful in terms of clinical practice. At the 3DN website can be accessed there. And finally, just an acknowledgement to say thank you to Julian and Rowan, who I pinched some of the content from their slides to make this presentation. Yeah, apologies for racing through. I was just noting the time as we went through.
You've done fantastically, Pramudie. Thank you so much for a wonderful talk and a really great introduction to all things relevant to managing people with intellectual disability, particularly those for our audience, the people that we might see when we're caring for people in mental health services. So I would at this stage just encourage everyone to, first of all, complete the poll. And secondly, to type any questions that you have for Pramudie into the chat, and then we can use those in the Q&A session, which will start now. Pramudie, I was really struck. I'll start off because I've got a couple of questions for you. Was really struck by the emphasis that you placed on talking to the carers, understanding what is the baseline. And that it brings me back to, a really fundamental in clinical history taking is who are the people that know the person best, because sometimes they're better able to articulate what the current problems are than the person him or herself, if that person's very distressed or unable to communicate for whatever reason. And we see this in mental health, we see it in pediatrics, we certainly see it in intellectual disability. So my sort of follow-on question is from that, if we were, for example, to have someone who's an inpatient in a mental health unit who we know has ID and they start behaving in a way that staff are finding difficult to manage, what would your approach be to involving the carer or the family at that stage? Would you routinely invite the carer to be part of a ward round discussion or a clinical discussion, or would what would your approach be? Because it would be good for people to understand what good practice would be.
Yeah, absolutely. I think when I have my assessments, it feels like an MDT. I try and get as many people involved as possible, because I think everyone provides a different lens and understand in order to understand the patient. So having the behavioural support practitioner who may have lots of objective data that they've looked at, and they're able to present that data, I think is really helpful. And then being able to speak to carers and family to really understand what is the baseline for the patient, what are the specific changes that have occurred, I think is really helpful. And so I think it's getting that subjective data and that subjective kind of understanding of the patient and what's going on. But I think it's also really valuable to try and get as much objective data as possible. That's true both for kind of understanding to diagnose and understand what's going on for the patient, but also when you're starting a treatment plan, then to monitor what's going on and whether it's effective or not. I think it's important to have both that subjective and objective data. And if you're working in an inpatient unit, it might be something, something that you can capture that objective data yourself within the inpatient unit. The team can do that. And then comparing that to kind of previous behavioural charts that might be, from the group home or from what the family has kept records of.
Thanks, Pramudie. That's great. And that was actually one of the things you mentioned in your presentation when you're talking about introducing treatments, use measurement, use objective data, because then you're not just relying on people's impression. staff members come and go with different shifts, it might be difficult to get a really good picture of whether someone's getting better on treatment or indeed worse. But if we've got those objective data, that's a great way of recording improvement. So listen, we've got lots of questions coming through. I'm going to start with one from Katarina Nesberick, who says, first of all, thank you for a wonderful presentation. Would it be possible to receive the list of references? Because Pramudie, you've given us some great resources in the talk, including for the SSBP. So we will, Pramudie, share the slides with everybody, but would you also recommend the 3DN website or other resources?
Yeah, absolutely. So the 3DN website has a range of resources. It's got, there's a new ID Mental Health Connect web tool, which has been launched as well. And that can help link to other resources or services as well that might be useful for patients that you see. Wonderful.
Now, Gabrielle has made the comment, people with intellectual disability are overrepresented in the justice system. What options do they have for accessing services if they're in jail?
Yeah, so I think that's a really, really great question and really great point. So in terms of the services that I've outlined in the talk, I'm not sure whether SIDMOS does sort of in-reach into the justice health system, but 3DN has a clinical component to the work that we do. So that's one option in terms of being able to get some sort of second opinions or a tertiary referral for people in the criminal justice system. But also I think given the volume of people in the justice system that have intellectual disability, it would be really important to upskill people within the justice system as well. And again, 3DN offers a range of sort of education programs. And so that's something to consider as well. And I guess having more things like this where we might learn a bit more about intellectual disability is helpful.
That's right. That's certainly been a big help to us today, Pramudie. We've got a sort of related question. Any suggested resources or advice when conveying a diagnosis of intellectual disability?
What was that? Sorry, how to?
Any suggested resources or advice that perhaps you could provide when a clinician needs to convey a diagnosis of intellectual disability to an individual or their family?
Sure. So again, the 3DN website has what we call easy read resources. And so if you're specifically talking to a person with intellectual disability, those easy read resources might be helpful in terms of ways to describe intellectual disability and a whole range of phenomenon in kind of language that's appropriate. But I think apart from that, it's really like conveying any diagnosis to a patient, doing that compassionately, allowing time to discuss that diagnosis, that understanding that it may not sink in at the first review, but then having subsequent reviews where you might be able to discuss that. So yeah, I think
that's good advice. And those easy read resources on the 3DN website, we often use those, Pramudie. I think they're really excellent also. Pramudie, we've got one last question for you, but just while I read it out, I wonder if I can ask you to share just the last few slides. Thanks again. So Dr. Terry Lim has asked about the phenomenon of assaultative behaviours, especially in male clients with ASD, with or without ID, that sometimes can be directed to at family members, but particularly towards mothers. Do you know, is there any literature around this phenomenon?
I'm not sure about the literature, but I can, from clinical experience, I can say that that is something that we see, particularly mothers becoming kind of the victims of assaultative behaviour, not just with patients with ID, but I think across the spectrum of intellectual disability. And I think that considering that the safety of parents is a really important part of the work that we do. I'm not sure that there's necessarily a single cause for that, Often it's about kind of doing that behavioural analysis and understanding what the function is of that behaviour, and kind of tailoring the strategies to meet kind of what the functional component of that behaviour would be, or if there's an underlying diagnosis that we might need to treat that's driving that behaviour. But I think it might just be a fact in terms of mothers being around more often.
The ones that are around most. Yes.
Yeah, exactly.
Yeah, thanks, Pramudie. I might just ask you, Pramudie, now just to share the next couple of slides. We've unfortunately come to the end of the webinar. It was a fantastic talk. I'm very grateful to you. I just want to let the audience know that next month, on the 14th of June, we've got TRSP's very own neuropsychologist, Chloe Gott, who runs our cognitive remediation program through TRSP, and she's going to talk to us about translating cognitive remediation therapy into real-world outcomes. So we're very excited about that. And then one more slide to share, just to publicise to you all the Australian Psychosis Conference, which is being held in September at Brighton Les Sands, and abstracts are currently open, but if you'd like to come along as a participant in the audience, we recommend you to check in the website. And the final slide just gives you the contact point for our team, the TRSP team. If you have people with complex psychosis that you'd welcome a discussion around, or a second opinion on, or help with treatment recommendations, we'd love to hear from you. So last thing to say is just big thanks to Pramudie for a wonderful talk, Pramudie, and we'll share your slides with the audience, and we'll welcome you back perhaps another time. Thanks again, Pramudie.
Thank you.
Bye, everyone.